Nasogastric intubation and enteral feedings. Nasogastric intubation is the insertion of a nasogastric tube to manage GI dysfunction and provide enteral nutrition via the NG tube. Nurses can also give enteral feedings through a jejunal and a gastric tube. That's what the picture shows there. If you have a J tube, that means it's going to the jejunum of the small intestine, which is the very first part. If it's a G tube, it's a gastrectomy tube where it's going into the stomach. Or you can have an NG tube, a nasogastric tube, that can go into the stomach as well. Or you can have a feeding tube that goes down all the way to the jejunum. NG tubes can be used for decompression, which is removal of gas or stomach contents to prevent or relieve distension, nausea, and vomiting. You can have different types of tubes. You can have a Salem sump, which is pretty much the most common. It's in the picture there. You can have a Miller-Abbott or a Levine, or you can have feeding tubes, which have different names as well. We can use an NG tube for feeding, an alternate to the oral route for administering nutritional supplements. Those can be our Dobhoff tubes or our Levin tubes or our Duo tubes. We can also use NG tubes for washing out the stomach to treat active bleeding, ingestion of poison, or for gastric dilation. We can use an NG tube for compression if it has a balloon on it, to use an internal balloon to apply pressure for preventing GI or esophageal hemorrhages. That's usually called a Senston-Blakemore tube is the one that is used for esophageal hemorrhage, and it fits almost onto like a football helmet looking contraption, and then it goes down to where those esophageal varicosities have hemorrhaged. Before we can insert an NG tube, we need to follow some certain pre-precaution considerations. We need to know the prescription and the purpose. Is it for drainage? Is it for lavage? Is it for feeding? What is the purpose of our prescription for this NG tube? Again, we have to identify the client, explain the procedure, review their health history. Do they have any nasal problems? Are they on any anticoagulants? Have they had previous facial or nasal trauma? And have they had a past history of aspiration, which is breathing food or liquid into their lungs when they're not trying to? We have to evaluate the client's ability to assist and cooperate with the procedure because it's uncomfortable and we need them to follow directions like swallowing when we tell them and holding a cup with a straw. And we also have to establish a means of communication to signal distress. Usually we have the client raise a hand. Before we do the procedure, we have to do hand hygiene and set up the equipment, right? We have to get the type of NG tube that has been ordered. We have to have a fixation device for the tube to the nose to secure. We have to get clean gloves, water-soluble lubricant, a topical anesthetic if it's ordered, a cup of water and straw, usually a 30 to 60 milliliter cc syringe so that we can aspirate gastric contents. We need a basin in case they get nauseous and throw up. And then we also need pH test strips to test those gastric secretions for acidity to make sure that we are in the stomach before we get an x-ray. We need a stethoscope to listen to bowel sounds. We need a disposable towel to maintain a clean environment. We're going to need a clamp or a plug to close the tubing after insertion. Otherwise, the gastric secretions are going to leak all over your bed. Sometimes you can use the filter to plug up the tube. You need a suction apparatus if you're hooking the NG tube up to continuous or intermittent suction. Your doctor will prescribe either continuous or intermittent. You need gauze to clean the outside of the tubing after insertion. You need a device to also secure the tubing to the close, usually a piece of tape and a safety pin so that they don't accidentally remove it. We provide a disposable towel and we provide privacy. Before the procedure, we're going to auscultate to make sure they have bowel sounds. We're going to palpate the abdomen for distension, pain, and rigidity. We're going to raise the bed to a comfortable level for the nurse and put them in a high Fowler's position if they're able. That's 45 to 60 degrees. I find the higher the better. We're going to determine the best route to avoid septal deviation or other obstruction. So we're going to test their nares. Can they breathe through one appropriately and have it be patent? We're going to use a correct procedure for tube insertion, wearing clean gloves, and evaluate the outcome. Remember, this is not a sterile procedure. We determine the tube length by measuring from the tip of the client's nose to the earlobe and then down to the xiphoid process, or follow facility guidelines. A lot of times they want you to go 2 inches below the xiphoid process, or even further if you're doing a J-tube feeding type tube. If the client vomits during the procedure, we need to clear the airway and provide comfort prior to continuing. That is something that you would stop if the client starts vomiting. To check the placement once it's in, we want to aspirate to collect gastric contents and test the pH. Remember, normal pH is 7. The pH of our stomach should be less than 4. That's what's expected. We also look at the color, odor, and consistency of the gastric secretions to make sure they are within expected limits. Then we secure the NG to the nose. We need to make sure we avoid pressure on the nares. There will be a picture later in this presentation that will show you what can happen if you secure it too tightly. And then we secure it to the gown. The only way to absolutely confirm placement of an NG tube in the correct place in the body is with an X-ray. So after completion, you need to make sure that a chest X-ray is ordered to confirm that you put that NG tube in the correct place. If you've done this before in another life, we used to inject air into the tube and listen for bubbling sounds over the abdomen. That is no longer acceptable. We do not use that as a way to confirm. It's gastric content pH, and then a chest X-ray to confirm placement in the stomach or the jejunum. If when that X-ray comes back, we see that we have gone too short and the tube is not in the stomach, we may have to advance it 1 to 2 inches and get another chest X-ray. The blue pigtail on the Salem sump, the most common type NG tube, is for negative air release. It prevents vacuum pressure if the tube adheres to the stomach lining and allows secretions to drain continuously. We don't clamp that when the tube is attached to suction. We keep that open. And by open, we just mean it's not stuck into something else. It is just free to sit there. It's usually blue and white, and it just sits on the end of that blue part of the tube. Measuring output, providing comfort, and giving oral care can be delegated to a patient care technician, but insertion and maintenance of the NG tube is a nursing responsibility. Removal of an NG tube is also a clean procedure, so we wear clean gloves. Again, we tell the client what to do. We measure any last drainage, assess for color, consistency, and odor, make sure they're comfortable. After we have removed the tube, we make sure we document the condition of the tube, that it's intact and all the way to the very end, volume and description of the drainage, and then our abdominal assessment, including inspection, auscultation, and palpation. Complications of inserting an NG tube. This is the picture I was talking about. If you secure it too tightly, you can have problems with the patient's nares. They can become excoriated. We can also injure the inside of their stomach if we put the suction too high or we aren't paying attention and the patient is having problems with that. We can use a water-soluble lubricant on the nares as necessary if they're starting to get dried. Another complication is that you want to monitor for is dark coffee ground or blood-streaked drainage, because that could mean there's either bleeding in the intestine. That's your dark coffee ground type drainage, or blood streak means there could be a problem in the stomach where it's bleeding. So you need to monitor for that and report it immediately. If you notice that the tube is causing excoriation, you may need to move it to the other nair. For discomfort, we want to make sure we do really good oral care on these patients, help them rinse their mouth out with water for dryness, not swallowing it, but rinsing their mouth out. We can use throat lozenges, and swabs moistened with water can help with the discomfort. Sometimes physicians will prescribe a local anesthetic solution for gargling to help relieve the irritation, because it is sitting in the back of their throat the whole time. If their fixation device is coming loose or is too tight, we want to make sure that we fix that as well. Sometimes the NG tubes can become occluded, and that can lead to distension of the abdomen if nothing is coming out of the tube like it's supposed to. So we might have a policy and procedure for your facility to irrigate the tube to unclog blockages. That's going to be per your facility protocol. We can also ask the patient to change position in case the tip of the tube is against the stomach wall. That might help relieve the occlusion. And then we have to verify that the suction is working properly to make sure that's not the reason the stomach is becoming distended. Enteral feedings is a method of providing nutrients to clients who cannot consume foods orally, but whose GI tract is functioning. Does that make sense? They can't eat from their mouth, but their GI tract is still working, so we can still give them nutrients. We just aren't feeding them orally. There's different types of enteral formulas. There's standard, which is a milk-based blenderized foods. There's a modular formula, which has more calories, and it's a not nutritionally complete, but it's a supplement to other foods. And then we've got elemental formulas, which are already pre-digested nutrients, so they're not nutritionally complete either. They're not nutritionally complete either, but they are easier for a partially dysfunctional GI tract to absorb. And then you can have specialty formulas. If someone has a specific nutritional need, they need more calories. These may not be nutritionally complete, but we need special enteral formulas for people who have hepatic failure, people who have respiratory disease, or HIV infection. You don't have to memorize this picture, but you do have to know that there are different types of enteral formulas that we feed patients depending on their needs. If someone has gastroparesis, where their stomach isn't working, if they have esophageal reflux, where the stuff comes up out of their stomach and into the throat, or a history of aspiration pneumonia from their stomach coming up and then getting sucked down into their lungs, we're usually going to place that feeding tube into the intestine, past the ileocecal valve on that right lower quadrant and into the jejunum, the first part of the intestine. NG tube feedings are usually for short-term therapy, and that's up through the nose. When you have a gastrotomy or a jejunostomy, that could be for therapy longer than 6 weeks, and that's inserted surgically. So it actually is inserted right into your jejunum from the outside or right into your stomach from the outside. That would be a G tube or a J tube. Necessities for that type of tube might be neurologic and muscular disorders, brain problems, stroke, dementia, Parkinson's disease, cancer that can affect the head and neck or the upper GI tract. You're going to have to go directly into the stomach or the intestine. Any kind of GI disorders like inflammatory bowel disease or mild pancreatitis, you're going to want to bypass the stomach and go directly, or bypass the upper oral system and go right into the intestines. Respiratory failure with prolonged intubation and inadequate oral intake might also be indications for placement of a type of NG or G tube or J tube. When we are setting up feeding tubes, we have to review the prescription, make sure the type of formula ordered is the type of formula that we're giving that patient. The things we need for setup are a feeding bag, the tubing, usually a syringe compatible with the tubing, a stethoscope, a pH indicator strip, an infusion pump, an appropriate enteral formula that is ordered. We may need some sterile or tap water as a solution to irrigate. We need clean gloves, supplies for blood glucose if our protocol says we have to check blood sugar before we start feeding, so that we make sure we aren't spiking their blood sugar too high. And then suction equipment needs to be available in case of aspiration once you start the tube feedings. You can see on the slide there's a picture of what the bag looks like. Sometimes there can be a water bag and a feeding formula bag. When we're preparing the formula, tubing, and infusion device, we have to make sure the formula is not expired and that it's the correct formula for what the doctor has ordered. We have to ensure the formula is at room temperature. Colder temperatures can cause gastric cramping and discomfort. We have to set up the feeding system, and we have to mix or shake the formula, fill the container, prime the tubing, and clamp it. When patients are receiving enteral feedings, they have to be in a semi-Fowler's position, minimum head of bed height 30 degrees. Before we start tube feeding, we always have to auscultate for bowel sounds to make sure their guts are working before we start putting food into them. We usually want to flush the feeding tube with 30 mils of water before we start the actual feeding to ensure that the tube is patent. And then we use something like the feeding pump shown in the slide to determine the rate that it will go and how long it will go for. Enteral formula should never hang more than 24 hours. Some institutions say they should not hang more than 12 hours, so make sure you check your facility protocol. For intermittent feeding, you're going to have a 60 milliliter syringe. You're going to remove the plunger, And then you're going to hold the tubing above where the feeding tube goes in, so above the nose or above the stomach if it's a G tube. Then we open the stopcock on the tubing and insert the barrel of the syringe with the end up. Then we fill it with 40 to 50 milliliters of formula. We don't want to overflow that syringe. And then we hold it high enough for the formula to empty gradually via gravity. We continue to refill the syringe until the amount for the feeding is instilled. Then we always follow it with 30 ml of water to flush the tube and prevent clogging. Patients who are receiving continuous feedings should have their feeding tubes flushed with at least 30 milliliters of water every 4 to 6 hours. Your facility protocol will tell you how often you should be checking for placement, whether they get an x-ray every day to make sure it's in the right placement, or whether you use gastric residual pH. When we have someone on tube feedings, we always want to monitor the intake and output for 24-hour totals to make sure that our patient is peeing somewhere close, their output is somewhere close to what their input is. If someone is on a tube feeding, we always want to monitor capillary blood glucose every 6 hours until the client tolerates the maximum administration rate for 24 hours. So we really need to monitor what this feeding is doing to their blood sugars. Most facilities require you to discard after 24 hours, but make sure you follow facility protocol. And some facilities require gastric residual volume checks every 4 to 6 hours. That's to make sure that the tube feeding is actually going down through and into the intestines instead of just sitting there in the stomach. So you have to follow that protocol. They may have you slow down the rate or stop the rate if the residual is above a certain amount. None of these things can be delegated to assistive personnel. We have to do these all as nurses for our patients. Anytime we do something new on a patient, there can be complications. So complications could be diarrhea 3 or more times in a 24-hour period. Sometimes people don't tolerate these formulas very well. Fortunately, we have other formulas that we can substitute, but we also need to be monitoring for that. If they do have diarrhea, we can also slow the installation rate, notify the provider. We can get a dietitian involved to help figure out what the correct formula should be. If they're having diarrhea, we obviously have to do good skin care and skin protection so we don't have any breakdown in the perineal area. We have to monitor to see if they're taking antibiotics, because sometimes antibiotics can also cause some diarrhea, to see if we need to change antibiotics. And then when we start tube feedings, you can also get nausea and vomiting. So for those, we would slow the installation rate, keep the head of bed up 30 degrees, make sure the formula is at room temperature. Sometimes we can turn them onto their side. That makes it a little bit more comfortable and helps with nausea. But we do want to let the provider know if the patient on tube feeding is having any kind of nausea or vomiting. We also want to make sure the tube is patent if they're having nausea and vomiting. We want to aspirate the gastric residual volume, make sure they still have bowel sounds, and we may need to obtain another chest x-ray to see where that tube is sitting in their guts. If we think the patient has aspirated, has gotten some of this tube feeding into their lungs, that's kind of an emergency. We need to withhold and stop the feeding immediately, turn them onto the side, suction their airway if needed, provide oxygen if needed, monitor their vital signs, especially temperature, which could be an indication of an infection from getting that tube feeding down into their lungs. We have to monitor them very closely for decreased oxygen saturation and increased respiratory rate. We have to listen to their breath sounds to hear if we any rhonchi, which could be increased congestion. We have to let the doctor know. We have to order a chest x-ray to see if there's actually fluid in the lungs. Very important stuff. If we see some skin irritation around the tubing site, we can provide a skin barrier for any drainage and monitor the tube's placement. So it's very important that as nurses with a patient who has an NG type or a feeding tube of any kind, that we monitor for complications very regularly.